Welcome to the webinar, Can We Really Predict Suicide?, organized by the Center for Psychiatry Research at Karolinska Institutet and Region Stockholm. My name is Rück. I'm a psychiatrist and a professor at Karolinska Institutet, and I will be the moderator for this webinar today. So I think we all agree that suicide is a global health challenge, and this is the first in a series of seminars that aims to address suicide from a variety of perspectives. Today we are starting with risk assessment. Clinicians routinely assess suicide risk in patients, but how well can we really predict suicide? And is there anything we can do to improve the situation? With us today, I have today's lecturer and panel members. Seena Fazel, professor at Oxford University, who I will introduce in more detail later. The panelists are Karin Schultz, Secretary General of MIND, Richard Bracken, who is the Secretary General of Suicide Zero, and Lina Martinsson, who is the head of the clinic Psychiatry Southwest here in Region Stockholm. And we are really happy to see that this seminar has so many people attending today. There were over 1,000 people who have registered. And the seminar will be split up in two different parts. The first part is a lecture with Seena Fazel, with room for questions from you in the audience. And the second part will be a panel discussion together with the panelists. So before we get started, a couple of guidelines for these seminars. So this is a Zoom webinar, which means that you who participate can neither be seen or heard, and you can only see the lectures on your screen. We ask you not to press the raise hand function, and instead use the Q&A function if you have any questions. Click on the Q&A icon in the toolbar and enter the question, and I will read it later if we have time. Now we wanted to start by sharing a Mentimeter link with a couple of questions that we can discuss here with Seena before we start to set the stage for that. So I think you will find the link in the chat. And I think as soon as you enter the couple of answers that you may have to this, we will see what you have answered on the stage or on the screen. So the first one is clinical decision making better, the same, or worse than structured risk assessment tools to predict risk of future self-harm? So what do you make of this, the answers here? It seems that the same seems to be, it seems all kind of equally distributed, the answers even. Is that what you would expect, Seena?
Yeah, actually. So, equipoise in a way, which is good because it means that it's an area that research can really add something to if there's a sort of balance between yes, no, and the same.
Mm-hmm. Okay, should we move on to the next question then? Okay, and this is, I think, a common topic in suicide research. Is suicide too rare to forecast accurately? Any comment to this? I know you will speak about this later, but this is what the audience think here.
Yeah, I'm a bit surprised. I would have thought that. I'm pleasantly surprised because I would think a lot of people think that something being rare means that it's very difficult to forecast. So I think I'm pleasantly surprised by that.
Okay. Good. And then we have the last question here. That's about being too optimistic or pessimistic. But I guess it's about the accuracy, right, of our risk assessment. So do you think clinicians should have more self-esteem here, or?
Yeah, I mean, again, it's interesting that it's quite mixed. You sort of almost have equal numbers of pessimistic and optimistic, and not so many about right, which is probably good because I think it means that people are sort of open maybe to learn and improve their approaches to this question. So yeah, I think that's a good sign in some ways.
Okay, good. So I guess we move on to the main event here, and that's Professor Seena Fazel's lecture, of course. And we are very honored to have you as our first speaker in this series. And Professor Seena Fazel is a professor of forensic psychiatry at the Department of Psychiatry at the University of Oxford, and he's also an honorary consultant forensic psychiatrist and a Wellcome Trust Senior Research Fellow, and is widely known for his research on risk assessment, both regarding self-harm and violence. So with that, I hand it over to you, Seena. It's a pleasure to have you here today.
Well, thank you very much, and thank you very much for the team as well. There's a team, you know, who've been very helpful in organising this. So I mean, this is quite a newish area in some ways, and quite an exciting area of research. And to be honest, you know, textbooks are behind the curve on this, and actually most clinical guidelines are quite behind the curve, I think, to catch up with some of the new research, new developments in this area. So what I'll try and do in the next 45 minutes or so is try and give you really an overview of where I think the evidence is, the latest evidence is, and give you a few examples of how to do prediction, and maybe think through some of the implications as people working in clinical practice. So I should just say, you know, up front that, you know, a lot of the focus of my talk will be about methods, you know, how we do this. And so it may come across as a little bit cold and detached. I don't mean it to be like that. Obviously, you know, we're all human beings, and many of us are clinicians, and clearly this is a you know, this affects people in very different ways. So I don't want to detract from that. And I hope you understand that the reason I talk about these things in this way is because I'm trying to focus on the research side of things. So that's just really by way of introduction. And just also to say that, you know, I've been very lucky to work with a number of Swedish colleagues and collaborate with people at the KI in particular on this topic. I hope to do in the future. And the reason for that is because some of the best data in the world has been collected in Sweden on this topic, and also some of the best researchers happen to be in Sweden as well. So Sweden, in some ways, is the right place for this type of seminar and this type of question. So what I'm going to do is share my screen, and hopefully we can take it from here. So I'm just going to press the slideshow, and I'm hoping that's okay. So what I'll do in the next 40 or so minutes is to tell you a little bit about what happens currently, and then I'm going to talk about this subject by looking at some myths, and I thought that was just a useful way of talking about the subject, and argue for that there is a role for scalable, what I call scalable transparent models. Present you one called OXMIS, which has been developed in Sweden. If we have time, briefly touch on machine learning as an approach to this question, because it's very a very active area of research, and then look at some recommendations for research and practice. And as I say, I'm coming at this as a research seminar, so a lot of this is focused around methods and research. So what do people do currently? Well, I think currently most clinicians, when they look at suicide risk, they do the sort of standard things, and they sort of take a good history, a sort of detailed history, particularly focusing on symptoms, mental health problems, suicide risk in the past, suicidal behaviors in the past. And then they do what's called a mental state examination, which is a form of clinical examination where you look at a number of different aspects of someone's presentation, their appearance, and the way they talk, the way that their mood appears to you, and the way they're thinking about their situation and their future, and you put that together, and as part of that you may think about previous risk factors in the past, what I call distal risk factors, so things that happened some time ago, and you may think about current factors that are important, like their current thoughts about suicide, any plans they may have, whether they're feeling hopeless about the future, which is thought to be an important symptom, and the nature of their symptoms, in particular depressive symptoms, which again are associated with future suicide attempts and completed suicide. And then in part of the history, you think about protective factors. So you don't just look at factors that increase risk, but you look at factors that might decrease risk. And that includes having a family or young children. There may be other protective factors, like whether you have plans to do things in the future, and they're considered protective. And then I think clinicians then they try and weigh all this up together and then come up with some sort of binary category, usually high or low risk. And the difficulty with that is no one really knows what high is. If I communicate with a colleague and I say I think someone's high risk, do they know what I mean by high risk? And equally, if I say someone's low risk, do they know what I mean by low risk? And then even if we agree what high risk means, that let's say it means a sort of high likelihood compared to the general population. What does it mean in terms of timing? Does it mean in the next month, the next week, the next year? So I think there's a little bit of clarification required sometimes when you hear about these terms and how they're used. So I think current clinical approaches, they're a bit liable for uncertainty in what they exactly mean. So, and how well do clinicians do? So, I mean, this is what clinicians try and do, is that they try and come up with this high-low risk formulation. But how will they actually do in practice? Well, this has been an area of some research, not a lot of research, and I'll just show you a couple of slides. I might have to talk you a little bit through them, but one was quite interesting because this is the first one I've seen, is 1987, and it uses what's called the computer versus clinicians. So I think the computer uses an algorithm in 1987 to predict this is self-harm rather than suicide, and the black line is the computer and the dotted line is the clinician, and basically the further you are to this side of the curve, the more accurate your predictions are. And the conclusion of this paper was that the computer did better than clinicians, and it did particularly better at the sort of higher end of the risk scale, so people who are higher risk, which is up here, and less well the lower end of the people who have self-harmed. But I think the point of this graph, I won't talk a lot of, it's a long time ago, but the point is that people felt that at the time computers did slightly better. It's a slightly different question. Do clinicians do well or not? Well, on the basis of this, they do okay, but not as well as the computer. And the argument here was that maybe the combination is really the solution. Another review, and this is a bit of a wordy slide, looks at studies of clinicians and compares what clinicians do, looks at what clinicians do with what happens in the future. And what they found is they use these terms like sensitivity, specificity, and two other terms. And these are just ways of trying to attribute a performance to someone, someone's prediction. So sensitivity is basically the true positive rate. So on average, in people that, I think, and this is again self-harm, people who self-harm, about 30% of the time the clinicians were able to spot these in advance. And for people who didn't self-harm, it's better. So the true negative rate is better. It's 85%, but the true positive rate is less good. And on the basis of this review came to the view that classification means splitting people up into high and low, wasn't very accurate, because they felt that these aren't very high rates, 31% getting it right in terms of people who self-harm, and 85% getting it right in people who don't self-harm. And they came to the view that it wasn't, it was too inaccurate. And of course, that's a subjective view, what's inaccurate and not inaccurate, but that was their view. So can clinicians predict? Well, on the basis of yes, no, the view of the field has been that probably not very well, if it's a binary yes, no. Interesting enough, you actually look what happens in practice. In practice, if you look at people who die, and this is in people who are patients who then die after being in contact with mental health services. If you look at the last time a risk was assessed in someone that subsequently dies in the next year or so, most clinicians thought people were low risk, so they would assign scores of low risk. And this is done in the UK. So what they do in the UK is they write to clinicians in cases where patients have died from suicide, and they say to clinicians, in your last assessment before someone died, did you think someone was low, or what did you think of their risk? And clinicians by and large say that people were low risk. Of course, it's a strange method, of course, by asking someone historically what you thought at the time, because you may it makes a lot of sense to you that you would have thought someone was low risk if they've subsequently then unfortunately died. So as a method, it's not brilliant, but what it does tell you is that clinicians, if you believe this to be true, is that they're not getting things right. Their predictions are not are more than half the time not correct. And interesting, I put none exclamation mark, because of course no one has no risk, but actually the question is whether risk is low or none, which I think doesn't really it shows that there's a little misunderstanding of what risk is. My view, though, is that I think, and I'm going to present this in the next half an hour or so, is that I think if it's done well, it can help improve what's called stratification of risk, which means we can figure out, groups of people that need more treatment versus those that don't, and that's important for allocating resources in a efficient way. I think if it's done well, it can help translate the latest evidence on risk factors into clinical practice, because these tools, if they're up to date and you can see how they work, you can actually understand how risk factors influence and contribute to suicide risk. I think they can improve transparency and consistency, so you actually know why people are why coming to an opinion about suicide risk, and also consistency. So there's a sort of standard, it raises the basic standards, particularly in clinical teams where there's a lot of changeover. There's maybe people from different professional backgrounds. You sort of need a baseline way of talking about these and measuring suicide risk. And I think it's about assisting decision making rather than replacing it. And I think one of the things that's often ignored is that if it's done well, again, it can underscore, which is another way of just saying emphasize safety planning. And safety planning is something that should be done in all patient groups, really, that you come up with a plan going forward if someone has a relapse in their health, a crisis of some sort, an acute crisis, and that a prediction, a good quality risk assessment can sort of underscore it by emphasizing the need for it, because everyone has a risk, and this is just a way of sort of highlighting that. So what I'll do now is talk about some myths, and that's a sort of way into the topic of, can we predict suicide? Can we really predict suicide? So the first question was, is clinical decision making better or worse than tools? And we had that as, of course, one of the questions that we were asked up front. And what's interesting is there is some empirical evidence on this. And I show you a graph, and again, it's really just to help me remember what the answer to the question is. But what this is a prospective study, so it's people going forward. So the clinicians are here, the clinician general score, And the clinicians are looking forward about the risk of self-harm in the subsequent months. And this clinician score, which is reported as what's called an area under the curve, which is an overall metric of how well you can separate high and low risk. So it's about separating two levels of risk. And it's compared with these other tools. And one is called the MSHR, the Manchester Self-Harm Rule. And then there's a patient, their own opinion of their risk, and then some other tools, which I won't tell you about, but they are other, and they're sort of brief tools, most of which are not actually developed for suicide risk prediction, but are symptom scores or other checklists. And what's interesting about this study is that these are essentially the same. I mean, I know the numbers are different, but these are overlapping confidence intervals, or overlapping uncertainty limits. And so they don't really differ. So statistically, this is not a difference. They're all pretty much the same. And the clinicians, interesting enough, were from teaching hospitals. Teaching hospitals are university hospitals where they teach medical students and other students. So there were centers of excellence, and the clinicians, interesting enough, had the benefit of all these tools. So what they do is they use all these tools, and then they're supposed to come up with a score, having had the benefit of these tools. So it's not actually an either or, it's just sort of on top of these tools, what do clinicians think about the risk going forward? And my point is that it's not actually worse than as the Manchester Self-Harm Rule. And what is the Manchester Self-Harm Rule? Well, it's 4 items. So it's and if you score yes to any of these 4 items, you go into the high risk category. So you have a study which shows that clinicians aren't really performing much better than a really very simple approach, which just allocates high risk based on any of these 4 items. My point being is I think there's there is clearly some room for improvement. I think that's my point from this slide. The second, I think, myth is that assessment on its own will improve outcomes. So you see quite a lot of people saying, well, this risk assessment, these studies of risk assessment, they haven't improved outcomes. And I think that's a myth, partly because on its own, of course, it won't improve outcomes. It needs to be linked to something. So on its own, if you're thinking about preventing suicide, which is really the goal of all this research, what you need to do is improve assessment, but also link it to an intervention that's effective. And this sometimes is missed. And there's lots of research to show that. So there are some studies. There's a very, very good trial done in the States where they did a screen for suicide in the emergency department in people who have self-harmed. And they compared people who got a suicide screen versus people who got the suicide screen and an intervention. And they found that, of course, it's the latter group, the people who get the intervention, that do better going forward. So screen on its own is not enough. It needs to be linked to something. And that's an important, I think, part of the picture. Another myth, I think, is that people mix up what's called a needs assessment, which the guidelines often recommend, with a risk assessment. And I think they're quite different things. A needs assessment is necessary and is part of a good clinical examination, particularly in high-risk populations, but it's very different from a risk assessment, and they look at different things. So, for example, the strongest and most reliable predictors of risk are typically historical, like age, sex at birth, and previous behavior. These are not needs, but they happen to be the strongest risk factors. And so that's something to bear in mind, is that, if you just have a needs assessment, it's not going to predict risk. It's got a different task and a different set of factors that will be prominent. And if you just use that, you'll miss some of the most important risk factors that help you stratify risk and actually come up with some sort of prediction. And then another question that we had up front is that, and I do think it's a myth, is that suicide is too rare. I was pleased to see that most people didn't think that. Another way of that in this area is they talk about something called the positive predictive value, which I can talk about as well in a second when I show the slide. And you see this written, in some reviews by some prominent suicide researchers, so this is in one review recently, the prediction of future events like suicide cannot be adequately predicted because the event is of low prevalence. I mean, it's always very difficult in science if you say something can never be done. But I don't think that's not my view, and I don't think that's really consistent with the rest of medicine, actually. If you look at the rest of medicine, there are lots of low event rates which are accurately predicted. The best example is cardiovascular risk, and there are a number of studies that have looked at mortality risk and a variety of illnesses, including cancers, where you can accurately predict the risk, even though it's low prevalence. And I think the other thing to say is that it's not always about how well you can predict people going forward who are high risk. So there's a thing called the positive predictive value, which is if you think someone is high risk, how many of those people go on to have a suicidal event in the future, like self-harm or completed suicide? And that's often used as a metric, and people make a big deal of it. But actually, there's another metric which is the negative predictive value. So how well is the prediction of someone you predict to be low risk? How well is that prediction going forward? So how well is that true or not, that the person actually ends up not harming themselves or not dying from suicide? And that's sort of important because it's a way of preserving resources. If you have a very high negative predictive value in any risk assessment, you can actually then safely let those people be discharged from health services, and they don't need extra follow-up or extra needs assessments, and you can then focus your resources on the higher risk group who need more resources, more follow-up, and in any system with limited resources, you have to do this. You can't give everyone the gold standard treatment. So I think high negative predictive values are important because they screen people out safely and they enable resource allocation. And I do think there is a need to stratify based on risk, and you can cope with low positive predictive values if the false positives that you have with the as a consequence of that, the consequences of that are not harmful. So you add things to them. And I think stratification in medicine, generally is quite common. So this is from, community health, where that, it's about maximizing efficiency, improving outcomes. We need to think about who are the people that we need to focus our interventions. This is a form of sort of personalized medicine or precision medicine that you give people, the resources they need to address their particular problems and prevent outcomes that you need to prevent. Another way of looking at it is in suicide is just looking at two very simple risk factors. So this is a study looking at people who presented to hospital for self-harm. So it's quite a large study done in England and Wales, and this column is the women who've presented self-harming, and this is the men who presented to self-harming, and it's done by age bands. So you have 15 to 24-year-olds. In this particular study, 20,000 women who are 15 to 24 presented to a hospital over this period of time. And then in the men, it was a smaller number who were over the age of 55, only 2,766. So a much smaller proportion. And the point generally is that this older group, it was much smaller numbers in the older group compared to the younger group, but also very different by gender as well. There were some gender differences, so more women presenting who are younger men. And what they did in this study is they followed these people up for a year. So these are people who present with self-harm, and then a year later, they are followed up and looking at risk of suicide in particular. And what they found is really interesting is that in the younger women, there were 14 deaths, but in the older men, there were 29 deaths. And actually, I think that's the overall over 55s. Not in the older men, it was a bit less. It was about 3,000. And there's a 17 difference in rates based on 2 factors, just age and gender. And my point here is that just based on 2 risk factors, you can see there's a very large difference in subsequent risk. And I think the whole area of prediction in suicide risk is trying to say, well, are there more? I mean, what more can we do? I mean, here are 2 factors that you can make a huge difference in terms of your prediction. But what happens if you add another 5 or another 6 or another 10 factors? I mean, there will be some sort of ceiling on this, but just 2 makes a huge difference. And I also think that it also highlights the importance for health services that, from a health service perspective, do you want to give, are you able to give the same level of gold standard treatment to these 20,000 people versus these 2,700 people? And does that make sense from a health services perspective if your goal is to prevent suicide going forward? And if you do that, does that somehow dilute what's available? Or should you actually stratify and focus actually resources on the high risk groups? That is an important question. And I think it's important partly because what's recommended is that if people self-harm, so this is one of the papers, and it's consistent with some guidelines around the world, is that everyone gets 3 to 12 sessions of psychological therapy to everyone. So this is irrespective of risk. And I suppose what I'm saying is that that doesn't really make sense in a system where resources are limited. It doesn't make sense to offer the same to everyone. That it should be stratified according to risk, and hence how can we predict who's at high risk versus who's not at high risk. Another myth is that risk tools confirm systemic biases. So these are because they're based on historic data, they sort of make the same mistakes that people have made in the past, because you're sort of building on the historical data. The only problem with that is that whether it's true or not, I mean, it's sort of it's slightly a straw man argument, because of course clinicians and professionals are also biased. So you find that clinicians are tend to be optimistic, so actually they underestimate risk. Seems to be there's an over-reliance on recent events and inpatient behavior. If you're looking at patient populations, there's quite a lot of risk aversion. And like I showed, there's people identify people at low risk, which shows that actually a lot of the, relatively speaking, that there isn't a lot of accuracy in the way that clinicians do risk assessments. So I think this business about systemic bias is important to bear in mind, but also you have to compare it with what the alternative is. And the alternative is that if you don't have structured assessments, you may get other biases that go into the system. And those other biases often you're not able to test them or monitor them in the same way, because they're much more difficult to measure. Related question, and this is a core question really for today, is about whether it's predictable or not predictable. And I sort of built up to this to some extent, but it's really the core question. And my view is that I don't think it's I don't think that's correct. I think it's a myth. And it's a myth partly based on what we know, and I mentioned this earlier, which is that you have these events which people think are unpredictable, like your 10-year risk of a cardiovascular event. And there's a tool for this called the Framingham score, the Framingham risk score. And this is the most successful tool in medicine, and the most widely used tool in medicine. And it's a very simple tool based on 6 of these factors, or actually 7. And then you press on this button, it gives you your 10-year risk as a probability score. It doesn't say high or low, it gives you a probability score. And I think that's an indication of where I think suicide risk prediction should go. It should go towards probability scores. It's not about high, low, it's about probabilities. And that's where we can be more accurate and predict things going forward. And this is partly what we've been doing. So I'll show you some of this a bit later, but this is one way of testing if a suicide risk prediction is accurate or not in a population of people. This is Oxmids, which is a tool we've developed, and it's for people who are high risk, so people with a diagnosis of schizophrenia, spectrum disorders, or bipolar disorder. So in a high risk population, whose risk is higher than the general population, can you predict risk? And this is a tool based on 17 factors. And this is a test of whether the observed risk, so this is suicide risk of 1%, 2%, 3%, 4%, is different or the same as a predicted risk. And if it's the same, it follows this line. And if it's different, you'll see a deviation from the line. And basically, most of the people in the sample were at this lower end of the spectrum, and the tool performs remarkably well, actually. It's very close to this line. And so we say that, it's a well-calibrated tool. So based on probability risk, you can predict suicide risk in this high-risk population. And we just recently tested this same tool in Finland, in everyone in Finland, over a large 10-year period. And again, this is a similar graph. We look at observers and predicted, where the red line would be sort of perfect. And you see that actually it's quite close to the line. I mean, a little bit of under prediction at lower rates and a bit of over prediction at higher rates, but broadly speaking, that's very, very well calibrated. I mean, it shows that you can do this in high risk groups. And finally, there's another study that we were involved in, which is using machine learning. And this was a slightly different population of patients who we were trying to predict their risk after 90 days following a visit to a psychiatrist or a hospital. And again, what we're doing here is we're comparing what actually happens, and this is self-harm or death. It's mostly self-harm versus what we predicted. And this is based on the machine learning, so it's a more complex model. But basically, again, it's very close to this perfect prediction, which is the 45-degree line. But there is some empirical evidence that's quite new that shows that different approaches can predict risk, but it's in high-risk groups, and it's using probability scores. It's not saying yes, no. It's saying, we think people with this set of characteristics, they have a 20% chance of self-harming in the next 90 days. And yes, that's by and large true. 20% of them, so 20 out of 100 of those people will self-harm. Another myth is whether clinical decision-making will atrophy. Atrophy means we'll sort of, die or will become much worse. People become lazy and they'll just become checklist fillers. And it doesn't have to be like that. I mean, in oncology and cancer medicine, people use a lot of tools to predict survival, 5-year survival. So if you may have come across this among family members yourself, that when you diagnose with a cancer, you try and work out 5-year survival rates, and it helps guide what happens in terms of treatment and also other forms of planning. And there really, it's about augmenting and improving the craft of physician using these tools, rather than just replacing the person. So that really the physician or the health professional works with these tools to try and sort of augment, improve, develop their practice over time. And then finally, the final myth is whether the scores are too uncertain because they're based on group data. And there's this issue of what they call the G2I problem, group to individual problem. So can you assign information based on groups to an individual? And I think my view about this would be to say that yes, you can if the populations are large enough, so you can provide some precision, but only at the level of a probability score. So it doesn't work so well with yes, no, but it seems to work quite well by saying, well, someone with these set of characteristics, they have, let's say, a 2% chance of dying from suicide in the next year, or a 10% chance of dying from suicide in the next year. So it doesn't tell you whether that person is is high or low in a simplistic yes/no way, but it's sort of giving you a framework and a way of thinking about the risk, which is consistent, transparent, evidence-based, and can help, I think, allocate resources efficiently going forward. So that's all very well. I mean, the problem currently is that there are tools out there and they're not very good. And so part of the reason is because they've been developed for other things. They're mostly checklists for depression symptoms or suicide ideation at one particular point in time, and they're not about future risk. And so we even reviewed some of the current tools, and you know, the ones that are most regularly used in many clinical services, they've been developed completely for different outcomes. And so you have to be careful that when people talk about how rubbish tools are, well, yeah, that's fair enough, and I sort of agree. But there's no great surprise there, because they were developed for completely different reasons, and they're developed for cross-sectional depression symptoms. So why would you think it's going to predict something in the future which it was never intended to do? So briefly now, I mean, I'm just going to sort of move on to, you know, how we're thinking about suicide risk in terms of research and how to develop new ways of doing this. Look at precedents, and I think the key precedent in some ways, that one I haven't talked about, is the weather app. So what's interesting is it gives you a percentage score of rain. It doesn't say yes, no. And I think this is the big, I think one of the big problems in suicide risk assessment when people write about it. They're always thinking about this classification, yes, no. The research I presented first up was all about yes, no. But actually, with enough data and with the right methods, you can develop probability scores, and that can inform what you do. So it's not saying it's going to rain, yes, no. It's going to say, well, there's a 61% chance of raining at 7 o'clock. And that means that on 61 days, like today, in the next, out of 100 days, it will rain. I mean, that's all it means. It doesn't tell you whether for definite it's going to rain today, but it says, well, 61 days like today, it's going to rain. And that's a sort of modern way of thinking about it. It sort of captures the uncertainty, and I think and I think that's really where the field needs to go. The same thing as happens with the framing and risk score. We in the UK use the Q risk, which is a variant of the Framingham. It's got a few more items, and you see it gives, and this, I think this is my risk of a heart attack in the next 10 years is 1.7%, with a nice visualization of it. And we use this in all family doctors, all GPs are recommended to use this in people who are over the age of 50, and also people at high risk for whatever reason. And what that does is it enables you to have a conversation about what you can do to reduce that risk, if it's lifestyle factors, diet, exercise. And then when it's higher, you can even think about using a statin, which is a medication which is not harmful. So actually and that's important, that it's not harmful, the intervention. And these are models in cancer medicine which give you a prediction of your mortality risk in 5 years. And this is the one we use for prostate cancer, very common cancer in men, obviously. And again, probability score, not yes, no. So this is what we've been trying to do, is develop novel tools for suicide risk, and using good methods, the methods that have been developed actually in the rest of medicine, particularly cardiovascular medicine and cancer medicine, and really come up with simple, scalable, web-based, free, transparent tools, which people can see how they work, can use them, and can help inform decision making. You know, they can involve patients as well, and families, and they can see how these scores are developed over time. And the methods, one of the key things about methods is they're not about one statistic. You don't just look at positive predictive value or sensitivity. It's a range of statistics. And then when you sort of compare it, you don't want to just look at it on its own. You sort of need to compare it with something else, ideally. And I think, you know, the good methods often use what are called multivariable models, where they look at the how different risk factors interrelate with each other, and not on their own. So we've developed one, and I'll just sort of show you a little bit about it. It's based in Sweden, and this was the Oxmith one, and it's in all patients with schizophrenia bipolar disorder. We looked at suicide over 12 months. We try to use the best methods in the field, where we have large samples. We geographically split them up. We pre-specify all the analyses we're going to do, all the categories, how we're going to drop variables that are not going to add value, and present a range of statistics, not just one. And here are the risk factors. I mean, if you're interested, so these are the risk factors for people who for dying from suicide in 1 year after having a diagnosis of schizophrenia, spectrum, or bipolar disorder. So you can see, what it contributes. Male gender increases your risk. Previous self-harm, you would expect it increases your risk by 2.5 fold. And these adjust for each other. And the important thing to say here is that, the human brain can probably cope with about 3 or 4 of these things simultaneously. If I'm a clinician, I can sort of work out maybe a bit of age, a bit of gender, maybe a previous self-harm, I can factor it in, maybe drug and alcohol use, but anything more, I just won't be able to do that. I just don't have the computational skills to sort of factor that in and balance them out off each other. And that's what the value, I think, of tools are, is that they can do that. Calibration I presented, basically it calibrates very well. Here is the tool. You have drop-down menus. It's very easy to use. And at the end, it gives you a probability score. It doesn't go above 5% for 12 months because after about 5%, the models become a bit unstable. And our view is that, once someone's hitting over 5%, that's probably enough information you need to show that someone's at elevated risk and can benefit from either more active follow-up, some optimization of their current care, some just go through their safety plans in more detail, but then you also have people at much lower risks, and that can help stratify care and allocate resources equivalently. And I think here an important thing actually in this individual is because there's some risk of drugs and alcohol, that could be something could be added to their current treatment if they don't have that already. So the Oxford model is about probability scores, and it helps screen out people at low risk. I think it improves consistency because you have sort of one model that people can use. It's transparent, you can see how it works, anchors decisions in the latest empirical evidence, and I think it raises the ceiling of expertise, particularly I think in clinical teams where there's a lot of overlap. There's junior members of the team, and that can raise the ceiling. And I think underscores safety planning because everyone has a risk score, and this idea, like I showed you before, that you have no risk is meaningless. So other approaches, well, I mean, other people have written about, I'm just coming to an end here really, but other people have written about what else to do. And I think, so our guidelines in England actually say don't use them at all. So, that's another approach. And I think the challenge there is to sort of, what about, all the biases, like I said to you, about over-reliance on recent things, on optimism, maybe not just taking into account all the risk factors. There's also a lack of consistency or transparency. And our clinical systems, our risk assessments are very basic. It's just yes or no. I mean, it doesn't tell you anything more. And then there's an issue of efficient resource allocation, like I mentioned. If you don't have risk assessment tools, then, how efficient can resources be allocated if you're relying on, well, you're basically then assuming everyone should get the gold standard. Is that the way that medical services can run actually in most countries where resources are limited? A two-stage approach, which Kessler, who's a very well-known psychiatrist, professor at Harvard, has argued, and actually done some very interesting work on army veterans, another high-risk group. So what they're arguing is you do a screen up front, and then if the screen is positive, you do a more detailed assessment, which probably incorporates needs. And I think that's actually quite an interesting thing to consider, actually, that you actually complement a simple scalable screen with something in more detail. And then there's machine learning models, and I think the issue there is whether they can be interpreted, whether they're transparent enough, and whether you can operate them. So whether they can be implemented in clinical systems, I can tell you from my perspective, working in National Health Service, it will be tricky to implement machine learning models. I mean, we have enough trouble making any simple changes to our software in clinical systems. It takes quite a long time to do so. I'm talking years. So, I mean, to then have a complex machine learning model implemented into that would be a major challenge for a big healthcare system. And then finally, we'll just do a needs assessment instead and not worry about the risk. And I think that's actually another approach that's quite commonly argued. And I think the problem, again, for me there is a little bit about that only captures part of the important picture and it doesn't capture the elements about risk and the consequences of that, about resource allocation and who to prioritize any extra interventions for. Machine learning, as I said, I'm not going to repeat myself, but I think it's a bit early, basically, but I do think it has a role research-wise in exploring new risk factors. So in conclusion, I think risk assessment is possible. I think it's about probability scores. I don't think it's about simple categories like low or high or low, medium and high. And I think that's where the field's got very confused, actually, where all the argument has been about this low versus high classification. I think that I sort of agree with the argument that that isn't helpful. I think it should be embedded alongside clinical practice rather than replacing it. And clearly there's risks of implementing it, you know, about people just using it as checklists. It should, people still continue to need to engage with people, you know, in a therapeutic way and not just fill out forms, obviously. It goes without saying, I think. So this is really as an adjunct. This is the word adjunct, really. It goes hand in hand and can add some value around these areas that I've mentioned, and also the importance of safety planning, because everyone has a risk, and lots of people don't have safety plans in place. So thank you very much for your attention. That's my email, my Twitter handle, and the OxMIS is there for people if they're interested to use it as a research tool or you know, as a training tool and then finally just some acknowledgements. I've been working quite closely with some colleagues in Stein Henrik Larsen at KI and also some statisticians here in the UK. Thank you very much.
Thank you very much for a really interesting lecture. So we have a whole, very many. Actually, I was impressed by the level of the questions you got here. So I have a couple of questions before we let the panelists in, and I also. So my first question is prediction on the individual level? I mean, predicting who will commit suicide or die by suicide, rather, is that necessary for prevention, or and some people will have argued that it's actually not, shouldn't be our focus. There might be other avenues to prevent suicide.
Yeah, I mean, I think, you know, it has to be tackled on many different levels, suicide prevention. So I think there has to be a role for better assessment, you know, and then there has to be a role for better treatments, and then there has to be a role for linking the better assessments to better treatments, and then there has to be a role obviously for training, and then there's, you know, there's a role for public policy. So there's a role of many different areas have roles, and I think this is one area which I think from a research perspective, there is quite a lot of, I think it's quite an exciting area, and there's a lot of room for development. I think prediction is necessary for prevention, insofar as what it can do is it can, like I said in my talk, I think highlight the groups that will benefit from additional input, particularly high-risk groups, and also help more efficiently allocate resources, so by screening out low-risk people. Because, you know, I mean, in Oxford, where I work, you know, in a single night, there may be tens of people who come in who self-harm. And the idea that somehow every single one of those people should get a gold standard long psychosocial assessment plus 3 to 12 psychological, you know, therapeutic sessions is really not realistic. It's not feasible or realistic, and actually I think dilutes what's, you know, it actually takes away resources, valuable resources, from where you can really add some value, I think. So I think it's going to be part of a bigger picture and a much more complicated, you know, strategy to prevent suicide. But I do think it's a bit overlooked, and I think, which is why I think it's an important area of research.
Okay, thank you very much. So several people, Emil Andersson, Anna Lund, and others have asked about self-harm and suicide. So quite a lot of your slides mention self-harm, and so how would you use the evidence from different patient groups here? I mean, would you even consider non-suicidal self-harm to be relevant in this context, or how do you think about this?
Yeah, so I mean, I think the first thing is so I used it interchangeably, and I think one of the problems is that the field does use the research often is interchangeably talked about, and the problem from a prediction perspective is that the risk factors are very different. So, you know, just take very simple, the two most important risk factors, age and gender, are highlighted, are very different when it comes to self-harm versus suicide. So it's, you know, it tends to be older people and men where higher risk of suicide, and it tends to be younger people and women who are high risk of self-harm. So so in terms of prediction, you probably need different models if your focus is on the prediction of self-harm versus suicide. And I think one of the confusions in the literature is somehow it's all been conflated and risk factors are sort of talked about together. And I think one of the insights, I think, hopefully recent insights, is that really you need to be quite precise who your population is and what your outcome is. And so, you know, when you're developing a model, who's it for and what is it for, rather than generically use it for everybody. And I think that's something we learned a lot in violence risk prediction, that the models that work best are those that are specific in terms of who their populations are. You know, is it prisoners, or is it people in psychiatric settings, or, you know, is it probation, people on probation, and what is the outcome you're looking at? So in relation to your question, so that's one thing. I mean, in relation to whether it's non-accidental self-harm or self-harm as a generic label, it depends whether you're talking about it as a predictor or as an outcome. My own view is that it's probably easier just to talk about self-harm irrespective of intent, because either way, it's a huge problem in terms of morbidity, in terms of, you know, physical and psychological health going forward. And so I don't think of it very differently. I think it should be prevented, full stop.
So one other question regards that risks, the risk factors we are discussing here today. Do you think of them as causally linked to suicide? And if they're not, does that somehow, is that important for how you choose your strategy?
Yeah, so they're not causally linked. So these are, I mean, I'm using the term risk factors probably in a very imprecise way, but what I mean are sort of risk markers, or, you know, things that are associated with risk. And they don't have to be causal. And I think one of the important things in prediction medicine generally is the factors you use just have to be good predictors. They don't need to be causal. They're about using, you know, pragmatic models that are simple and easy to use, and that work. And whether they're causal or not is a secondary question. It's a key question when it comes to treatment, of course, because there you want to figure out what the causal factors are, because you want to figure out where you should target your treatments. But when it comes to prediction, it's different. I think the perspective is different, and it's not about causality. When it comes to treatment, I think it is about causality.
Okay, thank you. So one question from Åsa Maj Johnson was, are there super shrinks who are better at predicting than others? So I mean, I certainly hope, or I think many people would wish that it would mean something, that you have a long training and long experience. I think a couple of your slides suggest otherwise, but is there a lot of individual variation that some are actually better at predicting such an event?
Well, there is a little bit. So it's a bit uncertain, the evidence. I mean, people haven't really looked specifically at that question, apart from that really early study from 1987. And I think that early study, 1987, which did show that the more experienced clinicians were better, and that the junior people were less accurate at predicting risk. I think that makes some sense, actually. I mean, the only problem there is if people get stuck into habits which are not very helpful. But I think, you know, with good reflective practice and, you know, if people do sort of keep an open mind about learning, I would have thought that experience does matter. But I don't think there's a lot of research. It's very difficult to research this question, but that would be my feeling.
Yeah, thank you. So another couple of questions have been about the well, what you refer to as atrophy, and clinicians usually or typically would assess short-term suicide risk rather than 10 years of risk for an event or even 1 year. So how well or could there be, how well is that studied? I mean, the next couple of days, next hours that you in a emergency setting, maybe the time frame that you use there?
Yeah, I don't think it is well studied, and I think part of the reason is it's just very, very difficult to study, and that isn't really very helpful to say that. But I think that's the reality, that people haven't studied it because it's so difficult. So, you know, I think but I still think, I mean, one of the important things to come out of the research literature, the more epidemiological research literature, is that these risks don't go away after 2 days or a couple of weeks, that they actually remain over the next year. And I think that's important to bear in mind, is that, you know, although as clinicians it makes sense that we focus on the short term, but actually the medium term is still important, you know, and most deaths will happen in the medium term, you know, in the longer term. They won't happen in the first week or so. Of course, there is likely to be an increased risk in the first week or so, but I think look at the whole population as a whole, most of the deaths will happen later on. And so I suppose it's worth bearing that in mind. And I think that's partly where I think cardiovascular medicine gets it right, I think, because they're really thinking a bit more longer term about, you know, everyone really needing, everyone either at a certain age or who've, you know, has had a cardiovascular event, needing to really think about their medium and longer term risks. I think for suicide tools, probably they're going to be mostly for 6 months to a year. I mean, that's the sort of range that makes sense for clinicians. And I take the point that, you know, some clinicians will want to know very, very soon, you know, a few days. I suspect that it's going to be too unstable to do that, and also very difficult to research that. So I think in the absence of anything different, I think, you know, we still would benefit from tools that can look at maybe more medium-term risk, like months and up to a year.
Okay, thank you very much. So I guess the last question, I know there will be many people who don't get their questions asked here. We apologize for that, but we don't have time, and I think maybe Seena has time to answer a couple of them in written or so. But the last question that relates to the previous one is, you suggested using probability scores like the weather app does. And Gergo Hadlatsky asks here if you want to use this for safety planning or stratifying patients into different kinds of care, wouldn't you have then somehow to categorize this anyway, like into yes or no, like the interpretation of the weather app, so to speak?
That's right. Yeah, that's spot on. And I think, but I think the good thing about that is that can vary, and that can be part of the relevant context. It can be part of a clinical services decision. Whether like I suggested, 5% or more for people with schizophrenia, bipolar disorder might be considered elevated enough that you need to do something different and add something to the current treatment. So I think you're right, but it provides you with a way of doing it that's a little bit more evidence-based, rather than just me telling you hi and then you don't know what I mean by hi, which is currently what happens. At least here you sort of know what I mean by hi, and you can have a discussion about it as a service, whether this makes sense to use that that cutoff. So for heart disease, for instance, we tend to use 10% as a cutoff for where you start thinking about statins, and then but it's also flexible. I mean, it's a guide, and it's not something you insist on, but you start at least having a discussion about statin at 10%. In America, it's 7.5%. So yeah, I think you're right. But it just provides, I think, a little bit more transparency and a little bit of a better framework and a little bit sort of more evidence-based way of looking at this classification issue.
Yeah, thank you very much. So there are a couple of questions about the OXMIS, and I don't think we have time to go over them, but could you just point people to where they would find more information about OXMIS?
So it's just on the website. If you go to the website, OXRISK website, you'll find it there. All the papers are there, published, and the coefficients are there, and there's a little user guide.
Okay, great. And thanks everybody for sending great questions. Now it's time for the panelists to join us for a discussion, and we have Karin Schultz, Richard Bracken, and Lina Martinsson in the panel here. And welcome to the panel. Who wants to go first? Karin, do you want to go first? I mean, Mind, the organization that you represent, just to give people context, are organizing the suicide hotline in Sweden, Självmordslinjen. That takes a lot of calls, and of course, I think it's very relevant for this discussion. So, welcome, Karin.
Thank you. Yes, thank you very much, Seena, for an interesting lecture, and it's this very hopeful message that we can somehow predict the risk of suicide. And it's really interesting to listen more about the probability scores. I have a question. A large group at risk, they seek healthcare for their psychological challenges and even suicidal thoughts, and then this assessment that can be made and done by a clinician. But we also have another risk group. Many risk individuals, they are people that encounter life crisis such as economic failure, loss of housing, debt settlement, etc. And they do not seek healthcare for that problem, but they meet other government social security functions. So what is your view on their role in assessing suicidal risks? And could an assessment tool be helpful for them as well?
Yeah, to be honest, I don't know. I think that's a difficult question. I mean, I don't know. I come from this, as a clinician, and so we deal with obviously people who come to our services who are high risk. I happen to work clinically in a prison, so I see people who come referred to me as because of mental health problems and suicide risk in prison. And one of the advantages there is that at least we know them in a way, and that we're able to provide interventions. Some of them they'll adhere to, some of them they won't, but at least the opportunity exists. You're asking about this other world, and other services, and what could work in there. And my only comment there is that there's a little bit of I mean, one of the challenges is you don't want to sort of overwhelm people and services. So if you have, let's say, tools with lots of false positive rates, and then all those people then are referred on to the family doctor, it will just create its own little problems. So I think it needs to be thought through quite carefully about what you would do in other sectors, in other services, and I don't really have an answer to that.
Okay. Thank you. I mean, the other issue question was also related to the lack of effective interventions, which is a problem which we encounter in the suicide helpline, that they have tried to they have suicidal thoughts and they don't get effective treatment. So, and is there a problem that these assessments, there you encounter a difficulty with when you don't have sufficient support, you don't get the treatment that you need and the psychological support. So is that a problem as you see it?
I think it's a large problem. Yeah, I mean, they talk about the treatment gap, you know, the difference between the needs and actually what people are then actually get. And, you know, it's very, very high for lots of disorders, particularly depression and alcohol problems, you know, are classic examples of where there's a large treatment gap. And what do we do about it? I mean, it's probably a topic for another discussion because it's very difficult. And I think, I mean, the only thing I would say about risk assessments is that what they can do is, if they underscore safety planning, then at least you have one little bit step forward sometimes in people who otherwise, you know, that can really add some value. You know, they know what to do when there is one of these life crises or relapse or, you know, financial problem, like you're saying, or housing problem, and you know, they can go to their plan and think through, you know, the steps of that plan. So that's one small thing that can happen. I mean, on a health service perspective, one of the things I'm arguing is that you need more efficient resource allocation, and these tools from a service perspective can help allocate resources more efficiently, and then that enables services then to in a way free up a bit of capacity to really intervene more targeted way at the people who are high risk, and therefore, you know, who will potentially benefit in terms of prevention more than others. So from a health services perspective, there's a role. It's not just about individual clinicians.
Thank you.
So if I may comment, I think related to what Karin said, there was a question that brought up if patients themselves or service seekers or whatever, I mean, the individual themselves, can they assess the risk accurately themselves? Because in the Mini that we use, a diagnostic assessment tool, there is the question to assess your own suicide risk for the next 3 months. Is there any research to suggest that would work? I mean, it seems intuitively not that, of course, the individual knows himself better than I do.
Yeah, I mean, the little bit of research that I'm aware of is this, you know, this prospective study where they showed that, you know, the patient's own idea of their risk, you know, was not worse than using some of these tools. I mean, I think one of the roles of these tools, I think, in addition, is that it actually opens up the conversation with the patient and their carers, you know, because you've got something to talk about. And, you know, sometimes clinicians find it very difficult to broach this subject in a sort of structured way. And here you can show, well, what's called a counterfactual. You can show them, well, what happens if you stop, you know, if you start taking your medication, or if you sort out this particular problem with, you know, maybe you're just continuing to abuse alcohol, because you can show them what happens to the risk. And so actually it's a way to open up and develop a more collaborative approach to risk planning and risk management, which is really where, you know, the direction of travel, of course, and it must be that way, that it's a collaborative plan going forward. So these tools might assist in that. I think they do, because they're just a framework to move forward from.
Okay, thank you. So I hand it over to Lina now for your questions or comments.
Thank you, Christian, and thank you, Dr. Fazel, for your lecture. Very interesting, and it's such an interesting topic. As a clinician, I think it's quite hard to do these predictions. And I wonder, do you have an advice for clinicians, or maybe, you know, what do you think of the future? What do you think, based on your research and all the evidence that we have today? What do you think? How do you think we should develop as clinicians, and in the ward? How should we sort of develop the way we work today?
Yeah, well, I mean, one of the ways obviously will be just awareness of the latest evidence, and that's very easy to say, but very difficult in practice, because every day there's 20 papers on this topic coming out. So how do you do this? So I'd say there's a role for good quality systematic reviews, people who bring together and synthesize the evidence, and that really is very important to support. So even clinical services can support this. Because it's not something that funding agencies like to fund, but actually it's quite important for people working, in clinical practice, that we need ways of bringing this together in way, in that captures this and makes sense of it, and so you don't just get distracted by one paper. You often hear people, and I in this country, I've worked with people in policy and government, and they talk about one paper, and you just think, well, hold on, that's one paper. It's a bit old probably, and I don't know what the sample is, and maybe it wasn't a great study, and they focus everything on this one paper. So there's a role for good quality evidence synthesis, I think, one, and then I think there's a role, I mean, in my view, there would be a role for these short, simple, scalable tools that don't take a lot of time. And what they enable you to do is, if your assessment is very different from the tool, you can sit back and reflect, well, why is that? Is it that I'm actually considering individual factors that the tool doesn't consider, so actually that's fine? Or is it that somehow I've focused too much on other things, and I haven't considered some of the historic factors sufficiently? So I think in terms of junior staff, new staff, trainees, I would say use these tools, because it sort of improves probably your skills. And I would say particularly more senior clinicians, if you're uncertain, then I would use the tool. So if there's some uncertainty, even within a multidisciplinary team, if people disagree, then using these tools can help actually have a discussion that's a little bit more organized than people just sharing their opinions. So I think I would say the three things, a little bit of evidence synthesis would be good for people who are new to this area of clinical work. Using tools, I think, will help improve their skills and knowledge of the risk factors. And then thirdly, I would say more senior clinicians, these tools can help them with uncertain cases or difficult cases, partly as a way of anchoring what they're doing in some evidence base, but also as a way of trying to clarify why there might be differences among team members.
Thank you. Do you think there is a role for biological markers? Biomarkers, like, for suicide?
Yeah, so I mean, I think there's a very active area of research, so no question. So it's a big area of research, and I think yes, I think in the long term, yes. I think the problem in the short term is how you actually implement that, because it's not most services aren't realistically going to be able to take blood samples or other biological samples of patient groups at scale. I think definitely, we're having this conversation maybe in 10, 20 years, that will be part of the conversation, and we'll have thought about the methods. And, I know people in this room are doing research on this, and that's important because we need to sort of move the field forward a bit. So I think yes, but I think we have to show, one, that it actually improves the prediction based on just using these simple markers like in the tools that we use. And second, can we scale it up so that it's not going to be a big drag, an expensive drag on services, that they have to take bizarre blood tests on everyone?
Okay, thank you, Lina. I hand over the word to Richard Bracken from Suicide Zero. I think the agenda of your organization is well explained by your name.
Yes,
or the name of the organization, rather.
And thank you for a very interesting lecture, and also promising. But I sort of, when listening into you, I sort of development as going in waves. And up to now, I really sort of thought that assessment is on the down. And healthcare is saying, well, let's do something else. It's not working. And now you're saying sort of it is working and we should do. And is there a risk, do you think, that healthcare will go in another direction now and say it's not working? And what's new in this that you've been talking about that sort of really adds on and say we should stick to it and do it?
Yeah, so I think you're right. I think it's on the down, and I think it's good that it's partly on the down because I think of some because the current tools basically are not very good, and the research has shown that, and I think it's very useful. In a way, you've got to sort of clear the decks in order to move forward with something new. And the only problem I think has been that what's happened is that people have sort of extrapolated from the problems that we have with the current tools and saying that everything is going to be bad. And I quoted you saying that it can never be done, you know, and people go on to say, and our guidelines here say, don't ever use them, ever. I mean, almost. They use this language. And how, I mean, you can never say never, I don't think, in science and medicine. So I'm very surprised by some of the language that's used. And I think you're right. I mean, I think it is on that. What's new, I think, is that what we've tried to do is we've tried to use methods that have been developed in the rest of medicine and applied them here. And that's what hasn't happened. And psychiatry has been a bit slow and mental health has been a bit slow to pick up on this. So we've used it. And then when you do it and you're very precise about what your patient population is, what your outcome is, you can get a little bit more promising information. So I think it's about what's new is basically the application of high quality methods. And I think you can see that in a lot of science. You know, once you start using better technologies, you get slightly better answers to questions that people thought were not possible to answer. And this applies, you know, in imaging for lots of medicine, in, you know, some other diagnostics that exist. And I think this is just another area where technology can be applied. I mean, we weren't able to do these big data models, you know, a few years ago. We didn't have the computational power. And it's that aligned with learning from the rest of medicine about how to do these properly, I think has been the big step forward. So I think you're right. It's on the down, but I don't think it should be. We say, you know, don't throw the baby out with the bathwater. You know,
Yeah.
you might have a similar saying in Swedish.
That's right.
Yeah.
Another thought that just sort of crossed my mind listening into your interesting lecture was the weather app and the like. You were talking about cordial diseases and so on.
Yeah.
And that sort of gives me a picture that a tool like a weather app for suicide prevention could be very public. And
yes.
For big groups with very low suicide prevention.
Yes.
Do you think it's good or bad if sort of peers should have a talk to each other what to do about the suicide risk I have with outside the hospitals? Yes. Instead of sort of eating more greens and cutting down red meat, could it be a similar broad conversation in society about how to sort of reduce risk for suicide, even though the risks are very small? Is that a good or bad development?
Well, I don't know the answer. I mean, you're in a much better position to answer that question. You and Karen are in a much better position than me to answer that question. So I'm happy to, you know, to learn from your views on this. I mean, the apps that we've developed are for high risk groups. So these are for patient populations high risk, and they're for clinicians to use because they use, to be honest, they use diagnostic information. So it has to be almost clinically led because it uses very precise definitions. Of mental health problems and previous mental health problems. So they are clinicians, not doctors, but other clinicians can use them as well. You know, it's doctors and other clinicians. But whether you're saying, you know, can you develop these apps for the wider population? I mean, I don't know, and whether they're useful, I don't know. To be honest with you, I just don't know. It's not what we're doing. I mean, we're looking at high-risk groups, and part of the way we think about suicide is that prevention. You know, at least for clinicians, we think that, you know, one area of important area of prevention is the high-risk population. So, you know, I work with prisoners. You know, this app we've developed is for people with schizophrenia and bipolar disorder, and a tool that we're just developing now and we just finished a project on is people who self-harmed and go to hospital. So these are high-risk populations, and we think that the advantage with those populations is that we have some interventions that work. and we know they work. There's good trial evidence for them. They're already in the system, so you can link them to interventions, and that that currently that we think these should be done by clinical teams, because they're the people who can make sense of them and work collaboratively with patients and their carers.
Okay, thank you. Thanks to all the panelists. We are about to close this session very soon. So I would want to say a few words about the upcoming next lectures that we have here. Let's see if we have a slide that shows now. So yeah, these are the next two seminars. They will also be online. This one has been recorded. It will be up on the website. You will all get an email where you can register for the upcoming seminars, but also I think there will be a link to the last one if you want that. So the next one is Niamh Mullins from New York, who will talk about the link between genetics and suicide. And I think that we already touched upon the questions of biomarkers here. This will be November 21st. And then in January, we are returning to the subject of prediction, where Craig Bryan will talk about under the title Rethinking Suicide, whose book Rethinking Suicide was out, I think, last year. It's a very interesting book, which may, to some extent, not complement the perspective of Professor Fazel here. So with that, I would like to thank everyone. There will be an evaluation sent to you in the chat or via email, so you can feedback what you thought about this. So thanks to Professor Fazel, the panelists, and all of you in the audience. Thank you very much.